Dear colleague, I am going to show you a case of hydrothorax in a fetus at 18 weeks. From the initial scans to the axial evaluation of the chest, we observe a normal 4-chamber heart and, in the right hemithorax, a slight fluid layer that lifts the lung apex, indicating a unilateral right-sided hydrothorax. Hydrothorax is excess fluid buildup in the pleural cavity and can be unilateral, as in the case under examination, or bilateral, which is more common in males. Furthermore, a hydrothorax is classified as primary when a diagnosis of exclusion is made and no association is found with other conditions, including chromosomal abnormalities, most notably trisomy 21 and monosomy X0 or Turner syndrome, nor is it secondary to infectious processes such as infections by parvovirus B19, cytomegalovirus, Coxsackie virus, adenovirus, or correlated with maternal autoimmune diseases. Among the various tests to be requested, the indirect Coombs test is always essential. In the case under examination, we observe that there is no association with heart disease. In fact, there is a normal left and right section of the heart, a 3-vessel view, and a normal velocity in the pulmonary artery and aorta. In fact, in 50% of cases, hydrothorax is associated with heart disease, and in 70% of cases with a condition of polyhydramnios. In this case, however, the amniotic fluid is normal. We do not observe any signs of ascites, generalized hydrops, or subcutaneous edema. It is therefore essential to carefully monitor the fetus over time with ultrasound examinations, and in addition to genetic counseling, it is necessary to carry out close ultrasound follow-up, since there could be an increase in the size of the fluid layer with compression of the mediastinal structures. In this case, the fluid layer is small, but there are situations like the one I am showing you of a severe so-called hypertensive hydrothorax, where the pressure of the fluid in the pleural cavity is such that it causes a shift of the cardiac area and the contralateral lung, thus leading to pulmonary hypoplasia and compression of the venous system with secondary hydrops. We also see that the differential diagnosis must be made with pericardial effusion. On the left, you can observe a case of severe bilateral hydrothorax with the lungs becoming centralized and visible next to the cardiac area, and there is a hyperechoic butterfly appearance created by the lungs, which are positioned in the central region of the mediastinum, while on the right there is a condition of pericardial effusion in which the lungs are not visible. Let's now move on to the quantitative assessment of the pleural effusion in the fetus under examination, and the largest dimensions appear to be about 4 millimeters by 3 millimeters. We see that the right-sided location, the small size of the hydrothorax, and the absence of association with other malformations allow us to improve the prognosis and to hypothesize that this could also be a case of chylothorax. Chylothorax is the buildup of lymphatic fluid within the pleural cavity, which typically presents as anechoic in the prenatal period precisely because chylomicrons will form later, once the newborn starts to feed. The lymphatic system is embryologically derived from the venous system, specifically originating from the cardinal vein. From the endothelial surface of the vessels, there will be the detachment, the budding of certain cells called LECs, which will gradually give rise to the primitive lymphatic stations that have a tubular and sac-like shape, and then to the lymphatic vascular system. So we see that the cause of chylothorax can actually be an agenesis, an aplasia, or a fistula of the thoracic duct. The goal of ultrasound follow-up is to assess the size of the hydrothorax over time and the amount of amniotic fluid. A severe hydrothorax, in fact, can cause compression of the esophagus, preventing the fetus from swallowing amniotic fluid and thus resulting in severe polyhydramnios. This could predispose to a premature rupture of the amniochorionic membranes and therefore to preterm birth. In more severe and complex clinical cases, therefore, it is absolutely essential and highly recommended to offer the couple the possibility of a specialized interventional medical approach. This consists either of thoracentesis, which allows for the drainage of fluid present in the pleural cavity, and therefore has both a therapeutic and diagnostic purpose, since if the proportion of lymphocytes in the aspirated fluid is greater than 80%, the diagnosis of chylothorax is confirmed. However, it is also possible to use specialized medical shunts, that is, drainage systems, which are carefully inserted into the pleural cavity surrounding the fetal lungs. These are known as pleuroamniotic shunts, so that there is a continuous drainage of the fluid present in the pleural cavity into the surrounding amniotic cavity.